to dig deeper into the topic of, I guess it was your number 4, the consensus area, which was design and delivery of training. And we are going to look at training techniques, timing, setting, media use to deliver training. And for that, for those who don't know, Julia Bluestone is a nurse midwife. She's an MS, Senior Technical Advisor at JPIGO in the Global Learning Office. And she's been working for more than 15 years all over the world. And she's an associate in the Department of International Health at the JSU Bloomberg School of Public Health. She's also co-chair of the USG India Working Group for Human Resources for Maternal Child Health Response. She's also a member of the Technical Working Group for the new Global Framework for Improving In-Service Training. Okay?
Okay. Thank you.
Thanks.
I just want to reassure you all that I am your last presentation, and we've requested the tea and snacks to come at 4 o'clock since we've done great on time. Thank you very much. As Alon said, we started the day very high level, looking at this really amazing body of work, and we've narrowed it down further, looking specifically at systems, and now we're going to share some of the just key points or surprising facts from a recent integrative review we did of the literature at JPIGO. Now, Alex mentioned a quick review. I would say this is somewhat a little bit above a quick review and certainly nothing like what they have undertaken. So we started out asking the question, specifically in the context of continuing health professional education, what evidence is there regarding different educational techniques, timing, which timing really, they're talking about frequency, single versus repetitive, setting and media used to deliver instruction. And then also what evidence is there about outcomes, specifically breaking the outcomes down into knowledge, skills, attitudes, provider behaviors, or patient outcomes for continued health professional education. We based these questions and our terminology and how we coded and categorized our articles on a conceptual model for continuing health professional education that was developed from a body of work done by the Johns Hopkins University Evidence-Based Practice Center back in 2009. So we used their conceptual model to help us with the terminology and the guidance. So like I said, I'm not going to try to go through all the findings of our technical report. However, there's a one-pager. I think you would have picked up a one-pager on your way in that has the link to our full technical report. So you can go to our Reaperline Plus, which is our new interactive website. You can download the report and look through 10 pages of data tables, which is much easier than looking through 500 anytime you wish. Co-authors up that aren't here, Peter Johnson, Judith Fullerton, Catherine Carr is here today, Jessica Alderman, and James Bontempo. So first, just very briefly, our inclusion-exclusion process. We did a literature search from May to June in 2011. We looked across the peer-reviewed electronic databases, primarily PubMed, Chinal, some of the others, Cochrane, of course. And we used terms related to continued health professional education, in-service training, continuing education, and from that we identified 244 studies. Now, as I mentioned, this is a modest review, so there were 3 of us looking at articles and coding and doing quality review as opposed to a body of multiple people. We did decide that we would include only grade 1 and grade 2, which for us, our grade 1 were systematic reviews or meta-analyses, and grade 2 included any type of comparative trial. So we ended up with 37 systematic reviews and 32 randomized controlled trials that we evaluated. So now we're going to move to the fun part. We're going to play a game. You don't have to get up, but I will be asking you to raise your hands. So I'm going to just go through some of these questions, highlighting some of the things from the report we thought were worthwhile to call out on techniques, timing, setting, and media used to deliver instruction. So first question. All right, systematic review. This is from an author named Bloom in 2005. Didactic instruction was found to result in which level of learning outcomes? And by didactic, he's specifically referring to knowledge push, Reading only, lecture only. So let's have a hand. Who thinks it's A? Hands. B? C? And the A's have it, actually, no to low. Results from the Bloom systematic review. I have a quote of his up here, although I will say he does go on to say in his analysis that, the way the studies are designed is so different, across the studies, that he said, there's still a role for didactic instruction along with other methodology, but we thought that was interesting. Here's the next. Techniques of the following, for which did we find the strongest evidence base to support it? A, self-directed. B, clinical simulations. C, team-based learning. You guys are the experts. Clinical simulations, yes. There are some nice work done across several systematic reviews, 4 in particular, that all really support simulation as a technique. Most importantly, it was mentioned for emergency situations as being very important, and also for knowledge and critical thinking skills. Which of the following has the strongest evidence regarding skill development outcomes? For skills, is it A, demonstration, B, using a checklist, C, practice and feedback? We've got multiple for practice and feedback. Practice and feedback, we found more to support that in particular compared to other illustrations. Of course, demonstration and using a checklist would be included in that. 3 different systematic reviews that looked at skill performance. And one thing I thought it was important is the dose response as being really important. They have to have sufficient practice and feedback for skills to transfer. So some of you may have seen this already. This is from a study in Kenya, and they used SMS messages along with distribution of new malaria clinical treatment protocols. And they evaluated the use of SMS messages and then looked at providers' performance reviewing case studies, reviewing charts, both immediately after the intervention was finished and then 6 months later. So the use of SMS messages without additional training, which do you think is correct? Is it A, B, C? It's actually C. This is really interesting, and actually it was I think the authors themselves went on to write another article 6 or 9 months later where they did 24 qualitative interviews with the providers to find out, why was this intervention so successful. So what they did is they did an intervention across 107 different rural health facilities in 11 districts in western Kenya. Now, one thing you will notice, this is the control baseline of the provider's adherence, and so you can see immediately there's something different between the intervention group and the control because they're already performing basically twice what the control group was. However, in the intervention group, these facilities were randomized and received 2 text messages a day, every day, Monday through Friday, and they were repeated. And these, I think, a long time, 3 months, I believe, or 6. And then what they did is they did the chart review immediately after they stopped the messages, and they found that provider adherence to the treatment protocols had improved from 20% to 50%. And then 6 months after doing nothing, they looked again, and they found this really interesting retention of still having providers 51% compliant with the treatment guidelines. So this is significantly better than their control group, and was really surprising to us that you would see this type of retention. I mean, it may be because the providers in that facility, everyone got the text messages. I mean, that might be part of it. But they did write, as I mentioned, an additional article where they delved into why did this intervention work. He does conclude in his in this first study, they do conclude by saying, SMS messages alone are not enough. It should be linked with training because 50% compliance is not what we want. We still want more than 50% compliance. But still, we thought it was really an interesting body of work. So on that note, we looked specifically at timing, also timing being single versus repetitive intervention. And so here's an example. Which of the following of these options do you think has a stronger evidence base to support it as a training intervention? So who guesses A, B, C? C's have it. Whereas some strong evidence, both from some interesting work out of Harvard Medical School and also across 3 different systematic reviews and several randomized controlled trials that found that repeated interventions are superior specifically for learning outcomes. Now, we found some interesting work out of, as I mentioned, out of our Harvard using the spaced education platform, and I'll talk about that in a little bit. So, speaking of, we'll get into that now. Also, we looked at timing, looking at repetitive short learning interventions, and by short I mean one case-based question, shown to increase retention by how much? 2-fold, 4-fold, or 8-fold? So A, let's have the A's. No takers. B, C. All right, 4-fold. This comes from, and I'm going to explain this, this comes from work, as I mentioned, done out of a group at Harvard, spaced education, which I know some of our colleagues are using in the field, which I think has been bought by a pharmaceutical. Now it's called QStream. However, they did, when they were working on this platform, it's a web-based platform that delivers messages that are repeated, questions with targeted feedback that are repeated over time. So you may do question 1, 2, 3, 4, 5, and then you'll get question 1 again. And those questions are repeated until you get each question correct 2 or 3 times. So you have distributed, spaced testing. And so this graph is from one of the BP Kerfoot studies that came out of the spaced education work, where they compared urology residents, 164 in each group, and they provided one group with 3 different web-based modules that had 20 questions each, so different questions. So they just went through the content one time. And then they had another group that went through spaced ed, and they went through the 3 cycles of questions, but they provided the same exact content for both groups. The blue triangles, they had repeated cycles, so they had to answer each question correctly twice for it to be retired. In this group, they went through them each once. So, and then they started doing testing. They did post-tests. So first they looked at the percent of improvement from the baseline, and you can see that for spaced ed, they didn't improve quite as much as the web-based group. But what we found really interesting is 50 weeks out, the web-based group has completely returned to their baseline or below for your intervention. And this group, you still retained 12% improvement from where you started. And they went on, they went on in several different randomized controlled trials. They compared, face-to-face teaching, one-time teaching. They looked at provider behaviors and residents' ability to give feedback. They looked at, just basic knowledge outcomes. And when you look, it's interesting, when you look at at what they actually did, they used case-based learning. And so they followed, when you look at educational psychology literature, they followed really nice instructional design. They were targeted questions. They gave targeted feedback. They used case-based learning, and I wonder if that's part of why their interventions were successful in every randomized controlled trial that they did. So, moving on to setting. This is interesting. This is a US-based study, but a small randomized controlled trial that looked specifically at emergency obstetrical skills, and they compared knowledge outcomes and skill performance outcomes using classroom compared to a simulation center compared to workplace learning. So the question here is, in this trial, did the setting all resulted in similar knowledge outcomes, true or false? Who says true? Who says false? This is the only one you are wrong about. It was really interesting. They did not find a statistical difference in the knowledge outcomes, but however, they did find that for when they did the team-based performance for the skill, they specifically administration of mag sulfate in a seizure and also managing shoulder dystocia, both in simulation. When they evaluated the team's ability to perform, the teams that were prepared either in the simulation center or in the workplace were able to perform the skill better than the team that was trained in the classroom. Now, again, that's a very small study, but when you look at the literature regarding situated learning and the benefits of having learning happen where you work as far as being able to transfer into practice, we feel like we can say that setting does matter, in particular for skill performance. We did find some evidence, and particularly from health professional education, like for physicians and nurses, that looked at clinically integrated teaching. This question is so easy. I'm not even going to ask it. All of the above. We found a couple small randomized controlled trials that looked at clinical decision-making skills comparing integrated teaching to interactive lecture. And obviously the integrated teaching was more effective. And they also suggested it may be more effective for practice behaviors, attitudes, thinking, and communication skills. Are there any questions about anything that I've presented so far that you want to ask now?
What is integrated clinical teaching?
Integrated clinical teaching is like teaching during clinical rounds or teaching during a post after the end of a session. It could be combined with like peer review. That was one thing that the JHU Evidence-Based Practice Center systematic review was really helpful for us, because what they did is this was done from 2006, I think, through 2009, and they said, oh, everyone's using different terminology. We're all, some people call lecture, some people say didactic, and so they prepared an article based on the literature saying these are the terms we suggest, and these are terms that we think should be used. And so that was helpful for us in defining some of the terms and using, categorizing in a certain way. Any other questions about anything that we've gone through thus far? Okay. So oops, I already gave this away, sorry. We have several different educational psychology literature that is referenced in the report, and you can look at talking about the importance of situating learning. Because we really did not find much, maybe Alex, we can pull that from their database, looking at setting, because we didn't find much in our more humble review. So switching to media, and let me just say that we define media as the medium used to deliver instruction, not how you use multimedia within the training. So that terminology was very sloppy. We did struggle with terminology in the literature. So when I talk about it here, I'm talking about the mode of media as a mode of delivery. So that brings us to our first question, is the evidence regarding computer-based instruction. Now, the caveat here is that this came from developed countries like Australia and the US, and not developing countries. So who says A? B? C? Okay. So basically, the US Department did a very nice meta-analysis. Again, this was looking at education in K through 12, and they pointed out that they found, in particular, blended learning, where there was some computer and some face-to-face. There was somewhat better outcomes, and they postulate that perhaps it's just because the learners had more time with the content. Mm-hmm. We did have a nursing randomized controlled trial that was done that found basically similar knowledge outcomes and similar retention. And they say, well, if your group is large enough, it can be more efficient. Also, 2 randomized controlled trials that found computer-simulated patients were equally effective for knowledge outcomes as live standardized patients. So here's another one on media. We had more than one systematic reviews that cautioned against which of these? A, B, or C? A, use of print-only media. Yes, that's correct. We found several, and the JHU systematic review I mentioned earlier specifically suggested use of multimedia, using different media to deliver your message, but that came across, and there's one systematic review that looks specifically at print-based materials only. That's the Farmer Systematic Review. So here's another question. We do not have enough evidence to support the use of mobile as a medium to deliver education. True or false? Who says true? Who says false? False? You guys are good. So I feel like this was, there's several limitations that I'll talk about with our work here. Media and pulling out some of the data on mobile use is definitely a limitation in our study. I know WHO is working on compiling that evidence base. We did find some interesting work from Dietrich. They work with point-of-care decision support tools on a smartphone. And they did, in simulation, they found a group that used a decision tree job aid for IMCI compared to the paper-based tool. They had better performance and compliance with the IMCI protocols. Another small study from China that found promising for point-of-care decision support. Another small study with community health workers looking at using a smartphone and media-rich job aids being preferable to paper-based job aids. And then, of course, the Kenya study, the Zoravac study I mentioned, with their sort of surprising results with the use of SMS messages, was something else that we thought was promising, but feel like that's an area certainly for more research in the settings where we work. So here is our last question, and then I'll go through our limitations, talk about some of what we're doing next. Media. Which of the following, based on what we looked at, which of the following is the best answer? The media you choose to deliver your instruction should be selected based on which of the following? Who says A? Who says B? Oh, who says C? Yes, effective techniques. One thing that became obvious to us, even though we're a small group, but when we started looking across the articles and the things coming out of data, that technique really matters. Technique being what you choose to do with your learner to help them meet those objectives. And so media, should be selected based on its ability to be efficient and also to use an effective technique. Any questions about any of the other questions that I just went through? No? So, a couple things and limitations. As I mentioned, this is a small group and a small study, and most of the studies that we found, because we looked for systematic reviews and structured controlled trials, were from developing countries. We only found, one from China, one from Kenya, and so that's a weakness in this, a limitation for us. And really what we're looking to do is evaluate some of the promising practices in low and middle income countries. And of course now we'll be able to pull from even richer data to look at what some of those might be. Also, another limitation is a lot of this work came from health professionals. There's a few here and there that were, community health workers, but so another question is, can computer-based learning be equally effective with lower level cadres? And what about the use of SMS? Is that really going to be an effective intervention for lower level cadres, where some of the research on mobile use in lower level cadres suggests that audio is preferable to text for utilization? So that's the other thing that we thought is a limitation, is important for us to look at. So what are some of the things that we're doing as a result of some of this is, for instance, in Ethiopia, we're exploring a BMONT course where we have increased the amount of practice and feedback, decreased the amount of lecture, and then we've added a series of 20 SMS messages replicating what Spaced Ed did, where they are repeated over time, and they have to answer the question correctly twice to finish the course and receive their certificate. So that's something, we've only done once, but we do plan to look at and then evaluate. The other thing we are experimenting with is, because we were surprised at some of the findings and the work that came out of Spaced Ed using the spaced, repeated questions with through the MChip program, we are using the QStream. It was Spaced Ed, now it's called QStream, but that same platform which delivers questions that are repeated over time and provides targeted feedback, links to videos. We are using that in our approach to preparing M&H champions, and we have several courses in English and also in French, as I believe some of our collaborators in the room also do. So to sum things up, and then I'll leave time for questions, is for us, and you can read, you're welcome to read the full report. You can download and read all the details, but I thought I'd summarize with the techniques because we felt like across the literature that came out is very critical and important. And, for us, choosing like case-based learning or simulation and really limiting passive techniques and really limiting content whenever possible was really critical and important. So with that said, I'd like to open up the floor for questions.
Before we go to questions, I would like Loy Schaefer to stand up and Mary Hamel. What happened here this afternoon couldn't have happened without the support of your organizations, USAID, CDC, and Gates Foundation, and I wanted to make sure we recognize that. So thank you. Thank you. Thank you for your support. So questions for Julia.
Questions from the floor? Going once? Yes, madam.
I was making one quick comment because I did spend a lot of years working at Chicago before doing it. I think that the real contribution you've made with this study is that you showed us the evidence. When I left there almost 9 years ago, we probably would have just intuitively would have put this exact same set of bullet points. I know you're laughing now. But having that backup of some real evidence and some sense of, yeah, we've been wanting to do the right thing, we know what it is, and now we have the data to support that. So
Yeah.
thank you for providing that to us.
Thanks.
Yeah. Alex.
Well, maybe other people are thinking questions. A very nice presentation today. I was curious about kind of the fundamental definition, if you will, of training, because Dan's study, Zorovec's study, was on SMS messages,
yeah.
which some people might think of as
Right.
like a reminder, and then I think there was another slide on job aids, which, again, I was curious, was there a much broader definition of training, or?
What we did, that's a great question. What we did, like I mentioned, the work that was done by the Johns Hopkins University Evidence-Based Practice Center, and that was more like your systematic review, a panel of experts, multi-year process, plenty of funding. And one thing they did is they outlined all the different techniques, and one of them was reminders. And of course, this was done, now the definitions they provided were done a long time ago. So even like mobile, I think back then were just basically Palm Pilots. So there were some limitations in using their terminology, but they included reminders, which is how we categorized the Zorovec intervention as a reminder intervention. Although you could also argue it's a point of care intervention. The terminology, even they say, the terminology is sloppy and people use it differently. So we refer back, and the report, the full report, actually provides that table of these are the different, this is the terminology and how it was used. So yes, for that, they did include reminders to be a training intervention. Although I would categorize it as like performance support, so. Any other questions? Yes?
I don't know if it's so much a question, but I just wanted to thank all of you. This has been really interesting, and I find myself, as I'm listening, having two or three thoughts. And one is, training is obviously about performance, provider performance, and it would be very interesting at some point, and I know we didn't have time, but to really talk about when we're talking about performance and defining outcomes based on, outcome measures based on performance. We all know how tricky that is. And to really evaluate quality of training, we have to be very clear about what those performance measures are. We know how challenging they are, so I would love to, at some point, amongst this community, have a more in-depth discussion about that. The other thing I'm thinking as I'm listening is, the thought is just escaping me. Different kinds of, we're talking about training generally, and I think Alex was getting at the point of, how do we even define training? But the thing I find myself really wondering also is to dig down further at some point to have a discussion about what kinds of performance are amenable or less amenable to different kinds of training. So questions around clinical simulation, it depends so much on what the performance is that you're trying to influence. And I'm sure this is a discussion that occurs all the time, and I'm sure all of you think about it, but I think it would be really interesting to also dig down more deeply into that. And then I just wanted to reinforce what came up in Tana and Diana's around situating the, thinking about training and performance improvement within a broader spectrum of pre-service, in-service, and continuous professional development, and accountability around that, because I think that's ultimately what will drive performance over the long term.
Thank you. That's a great thoughts. Any other questions? Catherine?
This is just
Comments?
just a comment, and it sort of bounces off of what Kathleen just said. As this moves from in-service training into the broader arena, including pre-service, and one of the things that will be important is to be able to address the situations that we see so often in low and middle income settings where there's one tutor to every 100+ students, and how to get away. How can we move people from that talking head lecture to something more interactive and more evidence-based?
Thank you. Other questions? Yes, Koki?
Yeah, I just wanted to mention, I think you spoke about the mobile technology and how it can work in improving provider performance, but I was wondering from the other presenters as well, how they feel like mobile technology will be included in the systematic framework or has been included, and how we are going to make the decisions about not over-reliance or the right amount of reliance on this and not let go of the other approaches that we know work. So I'm not sure what guidance would be needed for the field in the future to see how this works in an optimal situation.
Yeah, just a half an answer to a very good question. I have a colleague who was working on a review on the types of studies that have been done on mobile technologies, and there are quite a few, and a lot of them are actually still in process right now. So there are not that many final results, and so I think there's probably not so much that we can recommend right now, but I think your question is absolutely worth keeping kind of in the parking lot. And there are some studies that are, hopefully will be done within the next year or so. That's a very good question.
So it's a really important question. It's something that we also discussed with the consensus group, and there was a feeling that, we're talking about different contexts with different types of resources, with different levels of access to different types of technology. And so that's something that really needs to be taken into consideration. And so we did say that the use of technology should be explored and also the appropriate use defined for that context so that it is relevant. I don't think it's possible to really give a blanket recommendation. One, the evidence may not necessarily be there. B, it may not be appropriate to the context. Oftentimes when we look at the literature where mobile applications have been used, they've been used in the context of a particular project that's been supported by donors, and we haven't really seen this groundswell of Ministry of Health-led mobile interventions for learning, and it may be a while before that comes through. I mean, it might be maybe in the not too distant future where such modalities are eventually more efficient and cheaper to run and access is there. But at this stage, I think that's not the case. So it's something we have to look at and really consider the context for.
Any other last questions?
Yeah, one question for Tana and Diana. In the 6 categories, there was no mention of transfer of learning into the workplace. So there is support for learning. And I was just wondering if it came up during the discussion and where maybe it fits within the 6 categories. So many people being trained but not using their skills in their workplace because they didn't have the commodities or they didn't feel confident enough or there was no immediate follow-up for all kinds of reasons. So the system to support the transfers of skills into the workplace. Was that discussed?
Yeah, absolutely. And you'll see language around transfer of learning in the framework itself and the recommendations. So there are several aspects of that question. One is training the intervention that's necessary to address that performance gap? And as you're saying, it may be, but it might not be. There might be an issue of supplies, supply chain, might be an issue of infrastructure, the work environment that cannot be gotten at by just working on training. So that's one aspect. But where training is identified as the appropriate intervention to address the gap. The type of training, making sure that the design and delivery is using the best available evidence, the most efficacious and efficient way of delivering that is going to be key. And so there is language in the recommendations that speak to that. And supporting the learning is really supporting the transfer of learning into actual performance. Yeah.
Right.
And I would just add, I think that something that will be interesting to look into more is the importance of linking training with performance management as we're rolling out more performance management in facilities and how someone who is trained and that relates to their actual performance and how they're being evaluated by their managers.
Yeah.
Any other questions for the... Then I think I'll turn it over to you for a wrap-up.
Well, yeah, I think thanks, Alex. You have 729 interventions across 83 countries, so that's really incredible. And we're looking forward to seeing which strategy groups are most effective or cost-effective, and what are the attributes of the most successful training strategies. Again, and these are great insight that we will all benefit from. For Tana and Diana, really the 6 areas are quite specific and important, and I think it could be used. And we can all incorporate this into our work. So thank you again. And looking at techniques, timing, setting, media. I think for the first time, countries I think are really anxious when I travel. They're anxious because they have limited resources. 2015 is coming soon. And so it's really a question of where do we put our resources and what is the evidence out there to do that. And I think this afternoon has demonstrated that there is strong data that can help us move forward in helping countries to use their resources most effectively and cost effectively. So thank you all for coming. I think there is a tea in the back, and we'll see you when Alex is ready.
Thank you.
Yeah, thank you.
Thank you very
Thank you.
much.
Thank you.
That was so exciting.
Yeah.
Thank you so much. Oh my God.